But we have an exciting day planned, exciting hour. Another talent show format. If you came yesterday, you know the rules, but I'm going to go over them with you. I'm Al Berkowitz. I'm a physician, a CMIO, and a head of an innovation group. And I am just loving what we're doing here. Yesterday, we went through the semifinals. We found, we narrowed down the group that we have, all who were great, but we narrowed them down to 4 that we're going to show you today. We have a very wide variety. We have a .com company. We have a big vendor who's showing their newest product. We have a vendor who's been successful in other industries coming into healthcare for the first time, and a Canadian who's going to show us some of his data analytics work. To remind you, what we're doing today is not just showing this, but we're judging it. We have some of the most esteemed HIT professionals today. I'm going to tell you about the judges in a couple of minutes. And they showed yesterday that they're not here to gladden. They are here to let these folks know what they think, good and bad. And they certainly didn't hold anything back yesterday. And audience is part of this game show as well. You guys will get to vote. At the end of all 4 presentations, each presenter will have 5 minutes to talk. The judges will have 5 minutes to discuss and let you know what they're thinking. Ask the geeks any questions they want. At the end of those 4 contestants, the votes will count. You guys will vote using the cell phones. We'll show you how to do it. You can tweet at any point. There you go, hash mark HITx0, the number 0. You can tweet anytime you want, but you'll get to vote at the end of this. And remember, it's very diverse, hard to do apples to apples, but what we said yesterday is you're going to look at, what is the strongest of the HIT geeks? Who's going to be the king today? I'm going to suggest 3 U's. Is it useful? Does it solve a need? Is it really useful? Is it unique? Is it something different you haven't seen before? And is it usable? Is it really something that can be used, that your doctors will use, that your nurses might use, that you might use? And is it out there being used already? Is it something that will be immediately picked up if they put it out there? Those 3 U's are one way to start thinking about how do these guys measure up. So, let's get started meeting our judges. Dave Garretts, over to the right, raise your hand, everyone see him. Dave Garretts is the executive director of the advisory board company. I asked everybody to give me a little tweet about who they were also, a little more personal thoughts. He said, healthcare IT researcher, EMR adoption model co-author, HIMSS 50 and 50 awardee, former CIO and HIMSS chair, and guitar player. On my left, John Tice, Chief Medical Informatics Officer for Elsevier, emergency physician at Brigham and Women's, assistant professor at Harvard. His tweet, clinical decision support maven, design guy, real-world usability advocate, your basic industry, academic, clinical, government guy. So our physician representative on the judge panel, thank you. And in the middle, Erica Drazen, who is managing partner of the Emerging Practices Group in the healthcare section of Computer Science Corporation, CSC. Her tweet, healthcare IT researcher, MU blogger, HIT historian, grandma, and like I said yesterday, do not let that fool you. She was easily the toughest judge yesterday, and we expect a lot of her today. So without much further ado, we are going to start our contest, and we have our first contestant is our .com company. Your nurse is on call. Come on up.
Hello, HIMSS. My name is Matthew Browning. Our company is YourNurseIsOn.com. I'm a supervisor. I was a nurse supervisor for 12 years, and my standard line is that I spent 3 years of that on the telephone trying to find staff to come in and take care of our patients. As a result of that experience, I built an application called YourNurseIsOn.com. YourNurseIsOn.com is a software as a service that allows you to reach out to your healthcare workforce by 2-way text, phone, and email communications so that you can put the right person in the right place right now to improve patient outcomes, patient safety, and decrease cost of labor. You can see on the screen that we have a simple, usable internet interface Has your navigation down the left-hand side. You log in across the top. When you log in, I'm logging in as a nursing agency. Nursing and staffing agencies have the most complex functionality in the labor allocation business. We have different providers going to different customers, and you need to be able to match them successfully, and there's times you need to exclude certain providers from certain facilities, and our system has the ability to do all of that, from staffing agencies to simple facility, one way, this is my employee, I'd like to talk with them communications. Here you can see the system at a glance. If there's any pressing items, you can see them as soon as you log in. Are there people trying to become certified on the system and work for you? Are there assignments that are outstanding? One of the most common needs is, I've just had a call out. It's last minute. I need somebody to show up right now, in an hour, 2 hours, that short-term, immediate fill need. You click on I need a nurse stat, it pre-fills everything. You can select where you need to send somebody. You can change shifts if you wanted to. You can choose what type of healthcare providers are required. You can add any type of healthcare providers, assistive personnel, or support staff to that category. We're quota-based. You can pick as many as you need. I need 1, I need 2, I need 10. When those are filled, we will stop filling the shifts for you. You pick a date. You pick what time. We can work with your in-house staff, we can work with your subcontractors, or both if you really need to fill the position. Work status. We're able to call by part-time, full-time, and per diem so that we can reduce your overtime spend and most efficiently allocate your per diem staff where you need them. And departments are totally customizable. I have a couple here for our, for our emergency room and ICU, but you can add whatever you need and send them where they're needed. Messaging order can be set individually or can be set for your institution. Most folks would like to call by per diem, then maybe a 24-hour part-time person, then maybe a 32-hour part-time person with benefits, and then full-timers. You simply ask them to send this. Oh, didn't put the nurse assignment. You simply go ahead and send it. It'll confirm what you need and when you need them, and give you a decision point on how many folks are available for that position. We were going to get clever and call a couple of the judges, but the phones are all off for the wireless access, and folks who were here yesterday saw us fill a shift in under 2 minutes and explain what we do. At the bottom of this, you can send it out and get a confirmation. So you send it, it'll tell you, do you really want to do this? Is this who you need, where you need, and when you need? Yes, here's who's available, and you can send out that message. One of the other common functions needed is to be able to do multiple shifts. What do you do when you have the beginning of a month and you have a bunch of holes in your schedule that you need to fill? Are you really going to do this one at a time? I think that maybe not, in the sake of efficiency. So if you come and you pick any day in the future, you'll see we have the simple 7 to 3, 3 to 11, 11 to 7s, and 7A to 7P that healthcare runs on. But we can also make customized other shifts, which is the future of healthcare. Flex scheduling, how do we put the right people in the right place at the right time for something as little as a 2-hour or 4-hour visit. As we start to take a workforce that's aging and want to keep them from being fully retired, use them to help mentor our new nurses or healthcare providers, use their experience. Say you're an expert wound care or whatever your specialty is. We'd like to retain you in the workforce. So you can very easily do multiple shifts through our system there. And then blast messages. Every single organization needs to talk to their people. So routine and emergency messages can very easily be created here and sent out to your people. It could be a one-way message. This is the message I'd like you to understand. Or two-way. There's an in-service on topic X. Press 1 if you can be here Monday at 7 a.m. Press 2 for Tuesday at 3 p.m. Simple, effective functions. We put the right person in the right place right now to provide better patient outcomes. Thank you. My name is Matthew Browning, and we are YourNursesOn.com.
Okay, thank you, Matthew. So what we just had, we'll call, I'm going to summarize multimedia workforce communication tool. So it's a web-based, interesting area. Guys, I'm going to start, we'll start with John this time. Give us your thoughts. And I'm going to try and mix it up.
Fair enough. Hey, as long as the microphones are ready, I'm ready. Matt, good presentation. I think, first of all, just as a side comment, I think you get at least 5 points for being the only person I've ever seen to have a quote from Doug Hammarskjöld. I think that says a lot about the sophistication that's involved in this software. I think that yesterday you showed us a single workflow of coming out to a single nurse for a claim, and we challenged you to show us some broader workflows. And I think that you've shown some of that here with some of the broader block scheduling, some of the month scheduling, and so on. I think that if it almost seems like you're coming close to having a full-fledged scheduling app for your home staff as well as for your call-out staff. And it may well be that if you have sort of full scheduling capabilities, not just the call out, but actually make this part of a full-fledged scheduling, that'll give more people to say, hey, I need this anyway. I want the part I have to have. Now I can get these extra features that you have. So I think that's my recommendation, is try and combine this into a workflow that we're already doing. I think that what you have in terms of a brokerage, I think its time has come. I know it's been tried in the past in several ways, but I think that with the communications technologies now, this looks like this is in pretty good shape. So I salute you. I'd like to see this happen.
Thank you. And to address the scheduling piece, our plan is to actually be an add-on to the existing scheduling programs. So Kronos, McKesson, ANSOS, all of those different products we would like to integrate with and be their functionality piece.
And the question is whether you are wanting to work with them and be nice citizens and therefore have a better market that way, or whether you have a better market by being the whole solution.
Erica, what do you think?
Well, as I said yesterday, I think this is definitely needed in the marketplace. It is not unique for sure. I mean, we can just go out to the vendor floor, and I actually went out there yesterday and saw about 5 products that do the same thing. So it's not unique, but it's slick and cool. And so I think that one of the things that sells this is ROI. So do you have some ROI for this? How long does it take to make your money back through savings in less agency nursing?
So we have new implementations and don't have all of our metrics back yet, but some of the preliminary work shows that ROI can be as quick as 3 months on this, depending on how you're using the system. It's very inexpensive, it's easy to use, it's software as a service. You don't have to upgrade, you don't have to maintain. It's very easy and simple to use and inexpensive.
I also agree with Jonathan, which I actually do quite occasionally. So, and I do believe that this has got to be part of an integrated scheduling solution. I do not believe it's a standalone. I think that the competitors who have scheduling are going to be able to add this on themselves. The complication of 2 contracts, integration, whose fault is it that this isn't working, it's just not really worth it. So I'm not sure that this is going to make it as a standalone application.
Dave?
I agree with Erica, and Jonathan as well, which I guess happens all the time as well.
It happened yesterday.
Yes, it did. You said that you'd be integrating with Kronos and API and McKesson. Have you done it?
We're in full discussions with all of them, and we're in discussions with people who have proprietary systems that will not switch to Kronos, McKesson, or any of the market leaders. People like VA, HCA, they design their own, they have their own in-house programs and need this type of functionality. And it's not technically easy. It's a very difficult thing to achieve. And we planted an IP flag over 3 years ago. We have a full freedom to operate opinion, and I'd love to see that in some of the competitors. There's only one competitor that I would say, and that's Kronos with their mobility manager, and we're in discussions with them about augmenting their capabilities.
Okay. As far as Lyle's 3 criteria, useful, I think it looks to me to be very useful. I can imagine that a lot of organizations would like this capability. I just don't know how, I don't have a feel for how many of them have it already. So Erica said you're not unique. So I don't think you pass that criteria, but I'm just curious as to, in your view, as you have looked at the market, how prevalent is an application like this in existence now? How many healthcare organizations have this functionality at this point? What do you see as market?
Again, in our experience now, after 2 years of being in the marketplace and speaking to customers, the only folks that we see that have a comparable advantage or comparable piece is Kronos with their mobility manager, and they do not have a technological advantage, and we are distinct. They use things like short codes for their texting. We don't. We created a system that enables truly redundant, 2-way, multi-channel communication. We don't come back to a singular node so that you can communicate through IVR. If you do not receive a phone call, You can respond by the text. If you walk out of somewhere with no coverage, you walk out, you're still in play. You receive a message, you can text back a response, and it's a true direct line that engages our application. Also with the email, there's a link you click and you are confirmed, and nobody else can confirm or try to confirm after you. Those are unique. We've done international patent searches. We have filed international IP. We have a GE-trained international patent attorney who has been prosecuting this from day one. The only company she's ever become part of and invested in. And we have a technological, it's a proprietary technology that is not on the market at this time.
Okay,
Let
thanks.
me make one more.
I will let you. I'll let you have
follow
one
up.
thing then. Go
The
ahead.
dilemma you've got is that Kronos, when they complete their acquisition of API, is going to have 70% of the market.
Correct.
So you're going to go after the 30%. I would advise you to do that. That isn't Kronos's, isn't owned by Kronos. And, I think that's a pretty good sized market.
Absolutely, thank you.
Okay, okay, great. We're going to have our next contestant set up. Let me tell you a little background. Yesterday, if you weren't here, these guys each had 2 minutes each to do their presentation, which is insanely short. And you know, we just saw with your nurse's son, they could only show maybe part of their product. They had to get enough to get the judges and the audience to vote for them. So today, each of the contestants have 5 minutes now to show more of what they are, who they are, try and wow the judges and the audience a little more. Our next contestant, Mike Graham from Epilogue, is going to do that right now.
Well, is this on? Yeah. Considering the fact that I think I was the surprise advancement yesterday, and after a couple of receptions last night, I saw myself having 2 choices: get lost on the way here, or sing a song. I chose to sing a song. But I'll stick with the format. All right. So, this is a common phenomena, and the question that we pose is, why do HIT application users always feel like this? We do all these things. Of course we do all these things. But I would submit it's not working. I would ask you to consider this from your user's point of view. I would ask you to think about the level at which they work. I would like you to we have about 1 million employees under contract amongst our customers, and this is very, very common. And the problem with this is that it misses the point, because at the end of the day, end users have to take responsibility for their own proficiency. But this is where the crux of the problem lies. We believe that there are 5 requirements in terms of enabling end users to pursue their own proficiency. I won't pursue each of these right now in depth, because I'm actually going to talk about these, but take a moment to scan here, and in each case, there is an element of making it easier for them, of taking out effort, streamlining, and relevancy. We have a software platform, it's web-based. I'm not going to show it today, it's a little entailed, but we have 3 components to it. We have a component on the left-hand side called Author. That is an extreme productivity tool that captures content at the level never before possible. We have a platform, a web-based platform, for the management of that content. It has to be built for scale, because our customers create thousands of content documentation that their users use. And then you have to have a mechanism by which this gets to the users, and that is our Advisor product. Right now in requirement 1, we submit you must provide every scenario. The current problem is that it's a bottleneck. You have a situation where you have instructional designers or technical writers who create the documentation, but it's too hard. The tools they use are not up to the task, they're not up to the scale, and it is not done. It takes too long, it's too expensive. The paradigm that we create with our product is that our product is extraordinarily easy to use. As a result, you pull the creation of this very important content out of the hands of the technical writers and the instructional designers. You make them orchestrators, and the bottleneck is eliminated. Who does this? The subject matter experts in the organization, who are known and who get involved anyway, become the authors. They are the practitioners, they are the authors of the best practices. Who better than to create the documentation? So, requirement 2 says that different people learn in different ways. What you must do is present the content that is going to facilitate the self-proficiency. It ranges from HTML, XML, Word, PowerPoint, and a whole variety of different formats, because different people self-select and find what they learn best from, including simulations. And all of this is created from a single recording. When a SME records one of their transactions, all of this output is simultaneously created. The third requirement is that from the end user's point of view, they must not make an effort to get at this. If they have to call support, if they have to turn to a peer, if they have to search through a content library looking for a needle in a haystack, they won't. As a result, we have a tool that pushes it right to them, right where they are, in any application they're in, on any page they're on, in whatever work they are doing. We give them what they need without effort. And it looks like this. This is our most prevalent output, but all the other outputs are available and easily launched from this child window that just flashed at you. But we give people, for the specific work that they are performing, what they need right then and there, from which they can then launch any other of the formats they need, including the simulations, because some people would rather see and listen to what they need to do for a particular task rather than read and follow along. Again, this is done at a level of granularity that most major EHR, other CIS, and other transactional systems are comprised of. I was speaking with Meditech. Across their various modules, they feel they have about 10,000 transactions across their modules, a slim number of which are actually documented in this fashion.
Okay, we have to wrap it up, Mike.
The last requirement is that you have to provide users the ability to provide feedback and to improve. Our product also enables the ability to facilitate corrections, to facilitate feedback for best practice improvements, and it also monitors who's using what, when they're using it, where they're using it, and it tracks the results of their own proficiency testing. One of our modalities is a
We're gonna wrap up, Mike.
very much.
Thank you very much. Okay, so Mike just showed us much longer extension of what he did yesterday, so thank you, Mike, from Epilogue, for showing us that. Judges, let's see if you saw more than you saw yesterday, and what you think. Dave, why don't you start?
I think the comment that I made yesterday was that in the last year I've edited a book on change management, and it speaks to a lot of the stuff you're talking about here, but I think you're only addressing part of it. If it's worth it to healthcare organizations to do this, I think they should. I think they should improve the training that is done, and I think they ought to. I think that will improve the adoption and the efficiency of the users in using the system. It doesn't get to the main core of why users may not want to use the system, which is they don't want to change. And you know, you can shove this stuff at them, and they can do their best, but there's a lot of behavior change that needs to go on when you're implementing these complex systems. And I think a training module, you know, on our training capability, which is what you're doing here, is useful. I just don't know how useful it is in the broader scheme.
John?
So yesterday we all decided that you weren't our top choice, and the audience decided otherwise. So I spent some time trying to figure out what that was all about. And you know, I think you've given a broader exposition of what you do here. But I think I agree with Dave. I think, you know, yesterday I said, who actually reads help? And I think I'll stick with that. I think that, you know, what we've seen from the latest technologies, that people tend to shy away from things they have a hard time using, and that it's important to get them to get the things to not require that kind of help in the first place. That said, I think having help is something that people do sometimes. I think you probably need to convince people by verifying that. You need to go to some help desks and say, how many times have people called you up about something that if they only had help they could have used, and it would have saved them time and saved you cost. You need to show some kind of an ROI. But I think more to Dave's point, even if we're talking about using this as an ease of use tool, I think it needs to be part of not only help, but training, upfront instruction, sort of a tutorial program in the first place. I think it's a part of the solution, and I don't know that it's the part that people use the most.
Erica, what do you think?
Well, I think I agree with my fellow judges here that obviously our objective is to create systems that are so easy to use that you don't need any of these tools. It has also been shown, and my experience supports this, that people don't respond well to computer-based education, online learning, all this other stuff. They need hands-on training. And for this to replace the, hey, does anybody know how to do solutions, is going to take a whole lot. So that's where I am. I hope it's not needed. I hope it's needed less and less as we move forward. And, you know, your job should be to go out of business.
I agree, and from a usability point of view, what was interesting is we've had a major ER system, one of the top, who sent over their usability designer yesterday to look at this, and the guy just was going nuts, and he said we have to have this. The point here is that everything you say is exactly what we've encountered in 20 other industries, is the initial response. Once implemented, what they find is, because training, knowledge retention after training is this, it just plummets. There's virtually no retention. And if people have to spend any time working to get at what they need to be proficient, they won't. This brings it to them right when they need, where they need it. What's interesting is our biggest doubters, after deployment become our biggest supporters. I'm hoping that happens in healthcare.
I have a question.
Go ahead.
What I noticed about, and I've been privy to see some presentations coming out of Kaiser after they had spent, you know, $4.5 billion implementing Epic, and what they found was that people didn't learn anything more, you know, 2 years. They didn't know anything more 2 years after the implementation than they knew at go live. What they did was they did proficiency testing. So they said, what are you good at? You know, show us how you register a patient. You know, and the person would have to sit there and do that with them, and then they created training programs to help them understand how they needed to do this additional capability in the system. Does your software do any of that, or does it just provide help?
Yes, my long-windedness